This year's education session at ASH 2023 focused on how to really calibrate cellular therapies in lymphoma. And the main topic of discussion was about sequencing between two approved agents in the third-line setting for relapsed refractory large B-cell lymphoma, namely bispecific antibodies and CD19 CAR-T cell therapy. I think a lot has evolved in terms of outcomes for patients with relapsed refractory large B-cell lymphoma. Outcomes have improved for patients in the third-line setting based on 3 pivotal studies that were done, namely ZUMA-1 investigating axicabtagene, Transcend evaluating liso-cel, and JULIET evaluating tisagenlecleucel. All these 3 CD19 CAR-T cell therapy products showed an excellent outcome, and now at the 5-year follow-up, there's actually a plateau that's beginning to emerge at the end, which accounts for about 5-year overall survival across the 3 products of between 30 to 40%, demonstrating a curative potential for these heavily pretreated relapsed refractory large B-cell lymphoma patients. Given how excellent the outcomes were, and we know that post-auto transplant, not all outcomes are the same. We do know that primary refractory patients and patients who relapse within the first year of undergoing chemoimmunotherapy, they especially suffer from dismal outcomes. There were 3 randomized phase 3 trials that were launched that compared these 3 constructs against salvage chemo followed by an auto transplant in high-risk relapsed refractory large B-cell lymphoma. I think the net is that 2 of these studies, namely ZUMA-7 investigating axi-cel and Transform investigating liso-cel, were positive studies. They met their primary endpoint, namely event-free survival, and they have now been FDA-approved for patients in the second-line setting with high-risk relapse large cell lymphoma. So in terms of transplant eligible population, we have a product that works really well, better than auto transplant in the second line high risk relapse refractory large B-cell lymphoma study. So what about transplant ineligible patients? And to evaluate that question, pilot study was designed, which was a phase 2 liso-cel study evaluating transplant ineligible patients with relapse refractory large B-cell lymphoma. The net is that the overall response rate, the primary endpoint of this study was 80%, and it was met. The median PFS was about 9 months, and the median overall survival has not been reached. The safety was excellent on this study. There were no product-related deaths, and cytokine release syndrome as well as neurogenic toxicity in an older age group population were exceptionally well tolerated. There were no grade 4 or grade 5 events. So based on that, liso-cel is now also approved for transplant ineligible patients in the second line setting. So with regards to CD19 CAR-T cell therapy, we have it approved in the third line setting, in the second line transplant eligible high risk setting, and in the second line transplant ineligible setting. Now, clearly, there are the new products that have been recently approved, namely CD20 bispecific T-cell engagers, namely Glofitamab and Epcoritamab, and based on the 2 pivotal studies where these 2 constructs were evaluated, they are now FDA approved for patients in the third line setting. So after failure of 2 or more lines of treatment with large B-cell lymphoma, we now have the option to go forward with CD20 bispecific T-cell engagers. So clearly in this space, the biggest debate is how do we sequence these agents when CAR-T cell therapy is available in the third line space, and so is bispecific antibody treatment. And I do believe that I think it's really dependent on a lot of factors, but as we cross-compare across these studies, it is important to note that there is a curative potential that has been demonstrated with CD19 CAR-T cell therapy as a function of longer-term follow-up. That is not yet available for bispecific T-cell engagers, although with fixed duration Glofitamab, for the patients who achieved a complete remission, 67% of patients who were complete responders are still in a remission at the 18-month mark. So I think that's encouraging, but we need longer-term follow-up data. It's also important to state that the response rates, especially the complete response rates, were lower in patients who had refractory disease and were treated with bispecific T-cell engagers. They were in the range of 30%, versus if they had relapsed disease, it was between 50 to 70%. So clearly for the refractory patient population in the third line setting, my preference would be CAR-T cell therapy. Besides, antigen expression was an exclusion criteria in terms of CD20 negativity, was an exclusion criteria for BiTEs. On the other hand, we know that antigen density or expression did not impact CD19-based CAR-T cell therapy. There's an established CNS efficacy that we know with CARs that we know that we have not been able to demonstrate with bispecific agents. At the same time, I think there are distinct advantages to bispecific T-cell engagers, meaning they're off the shelf, so the manufacturing time and the delays go away. There's no need for bridging therapy. There's no need for lymphodepletion chemotherapy. There's certainly less upfront commitment as it might be for CAR-T cell therapy. Majority of bispecific agents could be given outpatient. CARs could be given inpatient, as well as most of it is now being given outpatient in major academic centers. But I think overall, if I was to talk about sequencing in the third-line setting, based on the established curative potential, longer-term follow-up, established CNS efficacy, and response rates in refractory as well as relapse disease, I do prefer CARs prior to BiTEs, bispecific T-cell engagers in the third-line setting. However, if someone has received a CD19 CAR-T cell therapy in the second-line setting, then my obvious choice is going to be a bispecific T-cell engager in the third-line setting. Now, being mindful of the fact that both of these agents are being tested and investigated in the upfront setting and the earlier lines of treatment, I think this debate is going to continue to evolve as our treatment choices evolve. At the end of the day, I do believe that shared decision-making and clinical trial participation will be key to successful outcomes for our patients.